So we're going to talk about skeletal dysplasias in about 15 minutes. Skeletal dysplasias, they are rare. They're not very interesting. They make sensible orthopaedic registrars talk nonsense routinely, but they frequently turn up in examinations. So this is where you'll expect to see a patient with a skeletal dysplasia. And they, unless you have got a system for dealing with these, they will cause you to panic. And all the reading that you've done and all the knowledge you've acquired, you won't be able to access just when you need it. And so what I'm going to try and do is to give you just the edge about being able to relax into a skeletal dysplasia case, recognising it for what it is, and then being able to come out with all the stuff that you've learnt leading up to the exam. All that detail won't be included. So what I think you're going to hear is clinical assessment, radiological assessment, know your enemy, i.e. certain key skeletal dysplasias that you just have to have some good information about, and some thoughts about sensible management. So clinical assessment is as simple as this. Is the patient short? Are the parents affected? Are the limbs involved? Is the spine involved? And is the face involved? So with that information, you'll be able to discriminate between a lot of the common dysplasias that you will need to talk about. That's just nothing more complicated than that. There are some dysplasias where they're tall, like Marfan's, but the majority are short. So if you've got someone who's substantially short, you should be thinking about, is this one of these skeletal dysplasia things? This is the fella from Game of Thrones. You can see he's substantially short. So standing height, this is a graph of normal standing height with age for normal population and achondroplastic population. And so the average height of an achondroplastic male is 4'3", of the unaffected male 5'10". So it's a completely different graph. Sitting height, if you look at, especially younger children in primary school, when they sit, it's much less obvious that they've got a height issue, because although their spine isn't normal, it's substantially less involved. And so we measure sitting height as a separate measure, and we've got a gadget for doing that. So arm span is another good clinical assessment. This is Da Vinci's Vitruvian Man, and if you actually look at the implications from the diagram, the arm span equals the standing height. So if either the arm span is less or more, it infers limbs are involved or spine is involved. So you need to know a little bit about how we describe these. And so Apley and Wynne-Davis, for 30 plus years ago, described relative proportions, either a short limb or a short trunk dysplasia, which was either proportionate or disproportionate. And so you describe his limbs in segments. Proximal is rhizomelic, middle mesomelic, distal acromelic, and it's the same for the lower limb. And the majority are either rhizomelic or acromesomelic shortening. So clinical assessment of face and head, in certain conditions like achondroplasia, you need to look at frontal bossing, shape of nose, in things like dystrophic dysplasia, cauliflower ears. There's certain key features about each dysplasia. The hands, again, this is a hitchhiker's thumb in someone with dystrophic dysplasia, and that's the trident hand in achondroplasia. And so the spine also has to be part of it. Is the spine involved? Is the spine not involved? And so with that information, so as the patient's walked in, you've had a cursory glance at all those things that I've told you about. So how do you put that together? Is there an inequality between the arm span and the standing height? So it's disproportionate. If it's disproportionate, which segment is short? Is it the trunk, which will be increased, or spondyloepiphyseal dysplasia, or is it the limb that's short? And if the limb is short, is the face involved? And if the face is involved, is it achondroplasia based on classic achondroplastic fasces? Is it dystrophic dysplasia based on things like cauliflower ear? Or is it others, such as the metaphyseal chondrodysplasias? So if the face isn't involved, is it pseudochondroplasia? Is it MED? Okay, it's not going to give you the diagnosis for all of them. It is supposed to just give you an idea that you can start making some fairly sophisticated diagnostic statements based on very limited information, and information that anybody should be able to acquire provided they know what they're looking at. And then you need to learn the radiological language. back to Apley and Wynne Davis. And it's which part of the bone? Is it the epiphysis, the metaphysis, or the diaphysis involved? And is the spine involved? And with those pieces of information, you can give a reasonably confident radiological classification. So with that, we'll call it dysplasia because it's a dysplasia lecture, but it's predominantly a metaphyseal involvement, and that is a metaphyseal dysplasia. You can't say any more about that based on just the radiograph. And in this one, again, it's a dysplasia, we'll give you that. It's an epimetaphyseal dysplasia because the epiphyses are abnormal, but the metaphyses are also widened. And there is a bit of a dark art to this. And in this one, it's a dysplasia. The spine's involved. There's flattening of the vertebrae at multiple levels. And the epiphyses are involved. So this is a spondyloepiphyseal dysplasia. Now, you can't make any more statements. There are other things you can do to sub-qualify it or subdefine it, but you can't do any more from the radiograph. So all you need is to remember, first thing is it a skeletal dysplasia, epiphyseal, metaphyseal, diaphyseal, and is spine involved? So the diagnosis is based on a dysplasia survey, which involves a lateral skull, a lateral spine, a chest, pelvis, one arm and one leg. Different to a non-accidental injury skeletal survey, which is a whole skeleton with high definition x-rays. But you should be able to get most of what you need from that. Also, diagnosis has been done more commonly prenatally, especially with very, very high definition ultrasound from 12, 13 weeks. You can start getting some good idea about a prenatal diagnosis of dysplasia. There are any number of gene panels to test for specific dysplasias, and so we're going more towards a genomic diagnosis, which can be prenatal or postnatal, which will replace the clinical and radiological diagnosis. And we're going towards a genetic-based classification, and every single dysplasia you can think of has got a recognised gene defect, pretty much. So let's look at some of them. The FGFR3, you'll know from your reading, is associated with achondroplasia, hypochondroplasia and thanatophoric dysplasia. And they're all classified clinically in the same group because they all look the same and radiologically. So we don't progress. The genetics proves what we've already assumed with the phenotype. It's the same with the collagen 2A1 abnormalities, which give you the spondyloepiphyseal dysplasia and other conditions such as sticklers. But they were already classified in that same group because they all look the same. But things like the metaphyseal chondrodysplasias have quite different genomic abnormalities, but they look the same. And so this gives us a much better idea about the ultrastructural changes. You also got to know your enemy. So there are certain conditions you have to know. You have to know about achondroplasia. I think you need to know about multiple epiphyseal dysplasia and how it mimics Perthes. Spondyloepiphyseal dysplasia, because there are certain clinical things you have to know about there. Osteogenesis, and then other things you may see in clinicals like multiple hereditary exostosis and enchondromatosis. So I put those as ones to concentrate on, and it makes me smile, and I feel very, very sad for people who are losing sleep because they can't remember the subtypes and the genetic basis for Ellis von Crefeld or something like that, because you're never going to fail any exam not knowing that stuff. So again, these are just features of, you'll need to look at it in your textbook. So achondroplasia, the majority are new mutations. It's an autosomal dominant inheritance with complete penetrance. If it's homozygous, it's lethal, we don't see it clinically. It's a very consistent abnormality, which is of the FGFR3 receptor, which lives on chromosome 4. And it's a point mutation of a single pair of base pairs, which leads to a missense mutation. And what does that mean? What the gene does, it's a gain in function of an inhibitor. So what it does is it increases the inhibitory effect on the growth plate, and so that increased effect on growth suppression. And you get inhibition of endochondral bone formation, leading to a very characteristic phenotype. You get macrocephaly, frontal bossing, and that's basically, it's sparing of structures that are formed in membrane, and more involvement of structures that are formed by endochondral ossification. Maxillary hyperplasia, the same thing, and in the limbs, disproportionate short limbs with a rhizomelic pattern short, broad hands, trident hand. You also get ligamentous laxity. And radiologically, you get short iliac wings and horizontal acetabulae. You get a coxa valga. You also get bulbous proximal femur. In the distal femur, you get a genoverum, and there's a V-shaped distal femoral physis. And so that's fairly characteristic of achondroplasia. And the fibula is less involved than the tibia, so that appears to be long. You get a narrow foramen magnum, which has implications with proximal spinal cord injury, especially in neonates. You get an Arnold Chiari, and you get spinal abnormalities, particularly a thoracolumbokyphosis in the infant, which tends to resolve by the time you start standing. But it's very, very angular. It causes an awful lot of unhappiness, but generally doesn't need treatment. And the particular arrangement changes. It becomes narrower as you go distally, and so one of the adult consequences of achondroplasia is of spinal stenosis, which is the most disabling adult feature of this condition. So yeah, short narrow pedicles, spinal stenosis. Sensible management is involved in diagnosis, genetic counselling, some thoughts about the prognosis, and then symptomatic treatment. So apart from the NAP treatment for achondroplasia, most of these are at the current time incurable, so it's symptomatic and supportive management. So the surgical issues are spine stability, spinal deformity, limb deformity, and joint degeneration. So you've got to know about C1 on 2 instability, because that affects a number of skeletal dysplasias, and that will lead to proximal spinal cord insufficiency or injury. So it's a really important thing to know about. Conventionally, flexion extension radiology was used. More often it's MRI scans, but some of these children we need to know about the proximal C-spine stability when they're neonates and infants, and so sometimes it's MRI scanning, etc. But there's a list of skeletal dysplasias, and the following are the ones in which C1 on 2 instability is an issue. Now, I don't know if your memory is any good, mine isn't, so I just assume, particularly in some like the COL2A1 deficiencies, that there is a proximal spinal issue until I prove otherwise. That's the safest way to be. Limb alignment is another issue, and yeah, there is merit in straightening them out for a number of reasons, but for me it's to improve the mechanics of the load-bearing joints of the lower limb, because quite often there are cartilaginous abnormalities in the joints, which mean there will be early degenerative arthritis as part of dysplasia. Add in unfavourable mechanics and that joint's going to fall to bits. The only thing that's surgically amenable, apart from an arthroplasty, is to straighten the limbs out. But if you do that and then subsequently need an arthroplasty, it's more likely that that arthroplasty will have a much longer life. Stature lengthening, again, this is something that's very, very popular. It's a completely different talk. It is available. It's been improved technically, but not necessarily decision-makingly, by intramedullary lengthening nails. But it is something that quite a lot of patients come to us certainly to discuss and occasionally to go through with them. And that's sort of a bit of game changer. That's an intramedullary lengthener, and it's made it a much more manageable procedure than with an external fixator. Joint degeneration, again, it's a combination of bad biology and bad mechanics. And I've already alluded to it. If you've got bad cartilage and bad mechanics, you're going to get arthritis, and it's going to need a joint replacement. And so the joints that are the hips and the knees, it's a conventional arthritic problem, but in a very, very difficult circumstance. So this is something that you need very, very high level arthroplasty skills. It's not for the beginner. It's a very short talk, so I've skated over most of it. What I think you've heard is some information on the clinical assessment, some on the radiological assessment. Know your enemy, that's for you to do in your studies, reading the books, learning the facts. Putting it together with sensible management, again, recognising that you can produce quite a lot of symptomatic improvement without necessarily curing this, and there are specific areas where surgery is relevant and some in which it's speculative.